Hi everybody, I'm Dr. Ejiro Isiorho from Corrective Step-Foot Health Center in Tigard, Oregon. There's a foot in front of me, so that means we're probably going to be doing a procedure. We're actually going to be doing two today. You may or may not be able to see, but this patient has a nice hammer toe, and not only is it nice, but it's actually exaggerated because they have a soft tissue mass on top. The toes are nice and betadine painted, so we're prepped. Our patient's numb. Are you feeling anything at all?
The other two toes.
Wonderful, but not on the surgical toe.
No.
Wonderful. So we're numb, we're ready to go. So pretty quickly what I'm going to do is I'm going to put my gauze around the other two toes because we're working on number 3, and sometimes that can actually create too much space. So you are going to feel your toes kind of go separate. That's intentional. So I'm going to get some temporary retraction with my hemostats and this gauze. If I need more, my assistant will be ready in a moment. So what are we going to take out? I believe it's either going to be a ganglion or it's going to be something consistent with gout. Gouty tophi or crystals, but that's the great fun about surgery. Sometimes you don't know what you're taking out apart from the soft tissue mass. And even when we take it out, we don't know if it really is going to be what we think it is until pathology gets a chance of seeing it. So now that we have the toe nice and isolated, get everything in the field. The patient has medication in. We have our cautery ready. Blades are sharp. Solutions are wet. Let's go to work. Incision. So I'm making 3 to 1 elliptical incisions to take this skin out and actually to go down to the toe and take the soft tissue mass out. I did not use epinephrine on this patient. I don't like using epi on toes unless there's something really indicated for it. So in this case I did not. So there will be some blood, but that may be why some of you guys are tuning in to see the blood anyway. Doing okay?
Yeah. Thank you.
You do look like you're going to watch now.
I'm pretending it's not mine.
There you go.
Perfect.
So now we have our skin, I'm actually going to take it out. That's the only sad thing about these videos is I don't get to listen to my music as loud as I want to.
You doing okay?
Yeah.
We do have more local or numbing medication if you need more, okay?
You holler at us at any time.
So we got that side loosened up. Let's get the other side loosened up. So what I'm doing is, this is called a 3 to 1 elliptical incision. So basically, as long as it is, it's 3 times as long as it is wide. Reason why we do that is for soft tissue or plastic technique. We can actually close it down pretty easily that way. And I'm going horizontal or transverse, so it actually blends in with your skin line. So when it's all said and done, it won't look like anything else but another little wrinkle on her toe, which is normal because we all have wrinkles on our toes.
Will you take out the burn or the spur if there's a bone spur in there?
Right now, I may not do too much bone work. We have a little bit of bone forceps, but if there's something that is easy to see, we're going to take it out.
Yeah, thanks. then that definitely will have sutures in, right?
Correct.
Yeah.
Correct. All right. Now we're going to try to find a stalk or something that's causing all this lesion to come about. I know I'll see it close to the joints because the way this these lesions usually come about and the location of it, it's right over a joint. So if it's a ganglion, then it's usually coming from the joint. If it's a gout, it's usually coming from the joint, or it's really within the soft tissue. So before I remove it in total, I like to kind of see from the skin lesion. And this is a skin lesion we're talking about right there in the center. That's where we're expressing fluid. So right underneath is where it's still adhered. So you can see I'm tugging on it, it's not really moving. So I'm going to try to find that stalk to see if I can find the stem of it, cauterize it, and get rid of it. So this doesn't come back, because these things really do come back. They have a high chance of coming back. Even after we remove it, there's still a 30% chance it's going to come back. Nothing yet. And I feel some wetness right there.
Is that betadine?
Mm-hmm. It's a lot in my sweet tea. I'm a southerner, so you know I gotta make it sweet. There we go. So now we can see if there's anything coming. There it is. I see a source. So right here, there's the stem right there. Let me take all that out. Clean this up a little bit more. And then we're going to start burning and suturing once we find that source. So the stalk, let me clean this up and show you. So right here you can see kind of there's a gelatinous area, and if I push on it, we may be able to get some material out. Any pain at all, my dear? Any pain?
No.
Okay.
Not yet.
Well, that's gonna heal. That's gonna come together really, really nicely. So there's a stalk right there, and I'm actually gonna see if I can take more of out. The enemy of good is better, so I always try to get.
Is that a bone spur?
No, it's soft. It's
Gristle?
yeah, gristly. So that's kind of consistent with the ganglion.
Yeah, because sometimes when I would take a scalpel and go around and get it out, it would be this hard little core.
Mm-hmm. So now that I see it, the goal is to scar it down so it doesn't want to come back. So I'm actually going to cauterize it, and then I'm going to put some material. There you go.
Then you put the cap back on,
On the
top back on.
I'm going to suture it shut.
Yeah.
Correct. No cap. So it's our disposable bovie. So like I said, I'm going to scar it. Sizzle, sizzle, sizzle. Now that that's scarred nicely, we're actually going to, like I said, suture it. And what this suture is, it's absorbable suture, because the goal is for it to scar down. So again, we want all this area to scar down and not be as mobile, and basically close up that hole where all that material is coming out. So I'd be more along the line to say that this is more probably ganglion. We'll take that lesion and we'll take it to the pathology and see what they tell us it is. But based on what I'm looking at, it looks like it's a cyst, not gout. But that's why we have the pathologist to let us know what it is. It's good for the goose, it's good for the gander, so we'll do one more. See if we can do one more in there. Yeah, it's looking good already. Let's do one more. I make sure I take that cauterize that burnt tissue. That's what we really want to make sure. And that's something that's usually abnormal, because usually we don't burn the tissue with a suture unless we're trying to create a scar, which we are. So I'm just doing simple interrupted sutures, and I'll close with a horizontal mattress because I want to evert these skin edges. I want them to come together really nice.
You doing okay? Fantastic.
All right, so now we're going to go skin. I'm using 3/0 nylon. I don't like to use absorbable in these kind of procedures because I want to be able to control how long the material stays in. So sharp's going to be over here. All right, my dear, we're on skin.
I are going to speak.
Uh-oh. Get the blood flow back.
That's fine, yeah.
So horizontal mattress suture usually goes in a box. I usually try to get the grab as much tissue of the skin as possible and basically evert the edges. Meaning instead of going in, they almost look like a volcano coming to a mound at the top. We'll see if we can. Wonderful. I'll probably take that one out. Right now it's holding. So you can already start to see the idea of what we're going for.
Now, is the top back on?
Yep, this is your skin. This
okay.
is you.
Okay,
Yes.
so we're anchoring it
He's
now.
bringing back the edges together.
Yeah. And the cap is back on?
The top is off, and we're going to keep that off, and we're going to hopefully make new scar tissue. But now we're putting the skin back together. This is a suture that we're going to take out, hopefully in 2 weeks. So every time I need to blot, I'm making sure to take my needle, or I'm sorry, take my hand off the needle so I don't accidentally puncture myself. What are these needles? I think I'm needing another nylon.
Okay.
Not very tough. Look at the needle in her skin. Sorry about that.
I have another one here.
Let's have that on standby in case. You okay?
Yeah, I see what you're doing. You're not putting the top back on, you're just putting the edges together.
Correct.
Oh, okay, gotcha.
Correct. Mm-hmm.
At that point, the top, it was additional skin that was stretched from the growth.
Yeah. And then if he releases the tendon on the bottom, it'll go out more.
Yep.
So,
Now you smell we're stepping in.
And there went your needle.
Somewhere. Thank you.
My goodness. Interesting.
Mm-hmm.
I wonder if it was just that needle.
I hope it was just that needle, because I don't think I ran into anything with her, bone or any kind of hard endpoint. So I don't.
Yeah.
Let's see what we're done. Usually 3 is all we need, but I'm going to do one more in that center just to bring those edges back together. And take this one out. I think your ride's getting a little anxious.
Sounds like he might have come back.
I can't hear you.
It sounds like your ride might have come back.
Oh, my friend?
Yes.
Yeah, this is payback. I took care of him for 3 weeks, that total knee replacement. His daughter pitched in and helped. It's a grueling experience.
We're on finishing up number 1 procedure. Number 2 procedure is not going to take much longer.
Okay, I'll let her know.
So probably about 15 to 30 minutes until completely done, and she's coming on her way out.
Perfect, thank you.
Will she call the medications in to Walgreens?
They've already been sent.
Oh, very good.
You're gonna get some antibiotics, 1 day worth of antibiotics. You're just gonna take 1 gram. And then you're gonna take the pain medication we talked about.
Yeah.
And then also
What's the antibiotic?
Keflex.
Keflex.
Yes.
Okay.
You have the cephalosporin.
And it's what?
Oh,
4 times a day?
no, just 1 gram.
Oh, just get the blood level up a little bit.
Mhm.
Okay. That top cap was kind of gristly, wasn't it?
Mm-hmm.
Like really tough gristle.
Yeah, that's what we're gonna send to the pathology so you can see what's going on in there. I'll take that. Okay. So now we're gonna do the second part of the procedure, which is actually gonna be the hammer toe. We're gonna straighten this toe out a little bit more. She's numb. There's actually a joint on the bottom where I'm actually gonna straighten this toe out, and we're gonna get everything ready for prepping. So with this toe, here we go. I've done these procedures before. You've seen them on the other videos.
Nice and easy.
Right now we're just swiping back and forth. We're cutting the tendon and we're hearing it release. And you will be amazed in a second. Each swipe, more and more releases until we hear no more swipes. And that's that. And just relax. And you can see how much straighter your toe is. You don't have that hump. You don't have anything like that.
Check that out.
I know. Now we flush, and relax, relax, relax. Relax. Very
Good, there you go.
Relax, Carol.
Nice.
Breathe, Carol.
You're going
Mm-hmm.
fresh air.
So with this tenotomy procedure we do on the bottom, we usually have our patients put a bandage on them, but since we are doing a procedure on top, we're actually going to splint this bandage pretty well, so they won't have to worry about it. When we see this patient post-operatively, they may have a little more freedom in terms of how they address the toe, but both of these procedures should heal up relatively unremarkable. Since I did 2 procedures on 1 toe, there may be some bruising, but that's to be expected. At the same time, take the pain medication, take the post-op medication for antibiotics, and then potentially with gout, we need to make sure you take the medication in case you have a gout attack. I'll take the gauze for gauze, please. Adapt it.
What about salon paws? I use a lot of salon paws on my shoulders, you know.
Right now, less is more, so just take the oral medication.
Yeah.
Once you start getting the dressings off, if you have any residual achiness or pain, then yes, you may want to
Salon.
do something else
Salon
different,
paws,
but right now, we're going to go with that.
When should the Novocaine start wearing off?
It's about 10 o'clock. 4 or 6 o'clock this afternoon. 4 to 6 o'clock this afternoon.
Oh, okay.
Yeah.
So if that's, then I'm going to take a couple Tylenol before that.
Correct. It's almost lunchtime, so I would say with lunchtime,
Okay.
take the antibiotics and take the pain medication.
At lunch?
Correct.
Yeah?
Yep.
Oh, okay.
Yeah, this is perfect timing. Look how straight that toe is. Look how straight that toe is. That's,
I can see it, yeah.
that's exactly what we want. So I'm very, very pleased with this. You did wonderful.
It's gorgeous.
Beauty's in the eye of the beholder, and I'm looking at it, so it looks beautiful to me.
I think it's gorgeous.
Well, I got to be part of it.
We all
I'm
have part
trained
here.
on this procedure now. Can you mark me off?
I'll take the roll gauze, please.
Like a nurse's training.
Thank you.
Okay, now you get to initial that. You can put a Levine tube down. You know, whatever.
We're all former, I guess I still am. We have a former healthcare provider working on. That's one thing I love about my clinic is I see all kind of healthcare providers.
Yeah.
You would not believe it, the amount of providers who come in and say, you know what, I have my own doctor, but I like
Yeah.
you. And that to me just tells that what we're trying to do is working, meaning people leave here educated, they know what's going on, they feel empowered, and they know that if they have questions, they can always reach out. So I do consults, I do secondary consults.
Education.
Oh yeah.
Hey, it has its price though.
Oh yeah. The burden of knowing.
Yeah. I'm turning into a mummy.
You are. We are mummifying this, but I'll take the cling or the Acrylics, please. Yes, please. I'll take some. I don't have scissors. I
Now
don't
I
use
get a
too much of
boot
this one.
Besides this?
You're gonna get a shoe, a sandal that's
Oh,
sitting right
okay.
there beside you.
I have a really, really cool post-op shoe.
Oh, thank you. Nice.
Very stylish.
Mm-hmm. And just relax. Just relax.
Oh,
Yep, yep.
Thank you.
oh.
There you go.
When I stand up, you're not relaxing. I'll take that ace, please.
You got it.
The mild compression, so if the dressing gets too tight, you can always readjust this bandage.
Okay, what I did.
This ace, if the dressing feels very, very tight, this beige ace wrap is what you can adjust, okay?
Oh, okay.
So sometimes you may say, this is way, way, way too tight. If you call myself or Amber or whomever,
Yeah.
we'll just say you can remove the ace wrap,
Yeah.
but when you ice, you want to make sure you ice on the inside of your ankle or behind your knee, okay?
Just right
Okay.
behind here.
Yeah.
And make
Yeah.
sure that you have a towel or something covering the ice.
Yeah.
So this is Dr. Still from Corrective Health Center in Tigard, Oregon, saying peace out, take care, be blessed.
Amen.